As a result of complicated phakic emulsification, this patient is left with a large temporal iris defect and significant photophobia and glare. The IOL was in the bag, and although an iris prosthesis can be considered, I felt a direct closure of this iris defect can be accomplished here. Notice the distensibility and the elasticity of the iris, and this allows us for direct closure. Using a polypropylene suture on a long CIF4 needle, this needle is passed through two ends of the iris defect. Notice the strategically placed incisions on the cornea, allowing us to enter and exit the eye here with ease using this long CIF4 needle. A docking cannula is used to prevent needle entrapment within the corneal fibers. A variety of suturing techniques can be used, including direct Malcolm mechanical suturing techniques, as well as seeps or sliding knots. Here we're going to basically extract both ends of the polypropylene suture through a temporal incision. And just like in the mechanical technique, we're going to tie the knot outside the eye, although here we're going to use a micro tire here to push the knot into the anterior chamber, thereby reducing the need to bring the knot outside the eye to tie it down or to cut. One also here can also use a seeps or sliding knot, although this technique here, as we're describing here, the McAhmed technique, is less complicated. The knot is then cinched down here, again using a micro tire through additional incisions as needed to bring both leaflets of the iris tear together. We will then lock the suture here, again using a long end of the suture to twirl around the micro tire, grabbing the short end and then passing into the eye, here locking the knot. A micro scissor is then used to cut the suture ends short. We continue to then close the defect here, again using this CIF4 needle on the polypropylene suture here, passing it through both sides of the iris defect and then removing it from the anterior chamber. Bringing both ends of the suture out of the main incision, tying it outside, again facilitated by a regular straight tire and a micro tire here again to lock the knot, thereby here locking and securing the knot in place without having to move the iris tissue much and keeping things in position. Micro scissors again help to keep incisions small. Here, although we don't have a frank defect on the peripheral aspect of this tear, we're going to oversew the suture here because of the thinning and the thinning atrophic nature of the iris in this area here to reduce the risk of photophobia. Similar technique is used again to tie the suture, and after the suture needle has been passed, locking the suture in place. We do have to still close the more central defect here, and we're going to pass the needle here through the pupillary margin. This does require a little bit of an artistic touch to ensure we have a nice round pupil. And although we thought we could salvage a small remnant of the pupil margin, we're going to release and cut it. And here we're going to show a complete intraocular tying technique here, in this case using two micro tires to do a triple throw into the anterior chamber along the long suture end, grabbing the short end of the suture here in the anterior chamber and cinching the knot in place and then locking it in position. Another approach here to suture the defect. At the conclusion of the case, after the suture has been cut, we see a well-formed pupil. We have the iris defect closed and minimizing the transillumination that may be present by over-suturing a little bit and ensuring we have large suture bites. The cosmetic, functional, and visual appearance here is improved with the direct closure using multiple techniques to suture the iris, as well as the tiny knots on the iris surface.